Welcome to Advanced Nurses. We connect with nurses who inspire other nurses by sharing their experiences. And so we're able to bring that information to you.
Hi, I'm the educational consultant with ACD-10 Advanced Nurses, and I am here with the coding nurse. And so today we are going to be talking about outpatient and inpatient CDI. There are a lot of nurses. I know I get a lot of contacts from nurses, whether it's through Instagram or even YouTube, asking about CDI. And many of the queries I get from these nurses, they are asking about how they can break into CDI. So um, I am going to cover the outpatient CDI space, which is within my scope and what I understand. And the coding nurse is going to be covering inpatient CDI, although the coding nurse has experience in both areas and extensive knowledge in medical coding and record reviews in both spaces and auditing in both spaces. So I'm going to actually just have you give our audience a brief rundown of your background and what you're going to be doing for us today.
Brief rundown is been in healthcare for a long time, got burnt out, transitioned into HIM in 2014 through risk adjustment auditing. And from there, I just wanted to learn more and grow and expand. And now I currently work in DRG validation, and I'm an approved instructor through AHIMA and AAPC, and I just try to help nurses discover that there are other options besides the bedside to use their clinical knowledge and expand their careers.
All right, so this is talking about nurses working in outpatient CDI. That's what we're going to be covering today. A few things we're going to be talking about today is key concepts in outpatient CDI, such as prospective chart reviews, retrospective chart reviews, provider ed touch points, measuring performance, and risk adjustment HCCs, hierarchical condition categories. This is a must if you're going to be working in outpatient CDI. So nurses working in outpatient CDI, some of the things that you need to understand is prospective chart reviews. So these are reviews or audits of the patient record to improve documentation and coding integrity. This is before the patient encounter. The retrospective chart reviews are audits conducted after the patient encounter. And really what you're looking for is those missed opportunities for you to improve the accuracy, of course, in the documentation and subsequently in the coding. So provider education, what does this really involve? So first of all, we have to understand that the provider is the true owner of their documentation. CDI is not focused on, cleanup. You should not, as a CDI nurse, be working so closely with the physician that you or the provider that you or the person telling the provider what the diagnosis is. It's really about them being the true owner of it. So it's about collaborating with the physician and the providers to improve the documentation practices based on audit findings and official coding guidelines. That's most important. If you're working in for an organization where they may be kind of winging it, because they don't have the expertise, you are the expertise. So you should be basing your findings and your education based on official coding guidelines and nothing else. You should be that source of truth, okay? And you should be the one championing that source of truth in the record. Risk adjustment and hierarchical condition categories. So refers to a payment model where patient diagnosis, they are grouped. So these are ICD-10 codes that are grouped in hierarchies, and these hierarchies essentially predict healthcare costs, making accurate documentation critical for appropriate reimbursement and quality reporting. So this is very high level. We can get into the details during, either a consultation or during one of our workshops. But this is very high level. If you want to do your own research to actually find out more about risk adjustment and HEC model. We're not going to go too deep in that, but we will go into some examples in some of the upcoming slides. So here's an example here. This is a clinical scenario. We have a 68-year-old patient with hypertension, and he's being seen in the office. Okay, so now you as the CDI nurse, you're looking through this patient's labs, and you identify in the labs that the eGFR is 38. Okay. And so the history and the documentation that you're seeing for this patient, the provider says the patient has kidney disease. So the provider now documents chronic kidney disease. So that is all that is in the documentation. Now, I can tell you right now, most nurses outside of CDI looking at a record, seeing that chronic kidney disease would say that this is just fine enough. The difference between a CDI nurse and a traditional nurse is that a CDI nurse is going to look at this documentation here and say, that's very vague, right? There should be more specificity here. So let's go on to where we can get that specificity. Now, under your clinic, this is where your clinical expertise comes into play. That there are stages of CKD. And so understanding those stages should help indicate to you as a CDI nurse, the specificity should be driven by the actual lab value. Now, one thing that CDI nurses should know, and this is where it's important for you to have that medical coding expertise. Coders cannot code from labs. So the difference between a CDI nurse and, let's say, a coder, some coders have that clinical expertise and they know that specificity should be there. They could see it actually in the record when they're actually going to code the record. But some coders may, because the documentation or if the code selection, there's coding compliance there. So let's say you can be specific. If there's an opportunity to be more specific, they may not necessarily speak on that opportunity because of the fact that they can code this unspecified CKD. So what makes the CDI nurse different is that CDI nurse is going to look at that lab value, right? And they're going to say to that physician, hey, can you be more specific about the CKD? Okay. Again, this is not saying coders can't do that, but this is what makes a coder different than a CDI nurse. In most cases, if it is guideline compliant, the coder would probably just code it as it documented. A CDI nurse is expected to look at that clinical value and use that as an indicator or evidence of that specific stage of CKD. Okay, so let's look at how it changed. Okay, so now the final and specific documentation and the impact. So now we have the stage 3B. Let me go back because I think I moved over that really quickly. If we look here, the eGFR, remember we said the eGFR was 38. If you look down to the stage where it says 3B, says moderate to severe loss of kidney function, look at the eGFR rate between 30 and 44, right? So that lets us know that 3B, based on that clinical evidence, would be the most appropriate CKD stage versus just having it as CKD unspecified. So we have the stage 3 CKD due to hypertension. Where did we get the due to hypertension? Let's go back to what was documented in the record. This is a patient with hypertension. They're being seen in an office visit, right? And the lab result says the 38. So here we have the lab documented, but we have the hypertension there. So that's where this hypertension is coming from. So we have this due to hypertension. So now I-12.9, hypertensive CKD stages 1 through 4 would be appropriate. Why? Because this specific ICD-10 code is indicative of, or it's for stage 3B. Now, if this patient had end-stage renal failure or stage 5, then we'd be using I-12.0 as the combination code. But this is the appropriate combination code to capture both the CKD and the hypertension. Also, according to official coding guidelines, you're going to also code the stage. All right. So we had an unspecified CKD, N18.9. Now that we have corrected that, by calling out the stage, we can get to the specificity around the stage being 3B. So that would be N18.32. It is very important for you to show the impact that you're having in your organizations. So, for example, tracking the impact of the non-specified to specified conditions. In many cases, that difference will take a condition from being non-risk adjustable to risk adjustable. Okay, this is the official coding guideline. This official coding guideline, as it states here, says assign codes from category I-12, hypertensive CKD, when both hypertension and a chronic and a condition classifiable to category N18, chronic kidney disease, are present. CKD should not be coded as hypertensive if the provider indicates CKD is not related to hypertension. So we never got that, right? So in the documentation, it said the patient had the hypertension. The provider also documented the CKD. So both of those conditions were present in that encounter based on that documentation. And there was that hypertension was not linked, or the CKD was not linked to any other condition, right? So we can use the causal that is a guideline, that there's a causal relationship between those conditions. So therefore we can use the combination code, okay? Oh, and let me also state this here. It is appropriate to code from categories N18. The appropriate code for category N18 should be used as a secondary code from the category I-12 to identify the stage. So what this is saying is that when we're coding it, the order would be that the I-12 would be coded first, the I-12 code first, and then after that you would follow up by the code for the N18 that we specified before 3.2. So we want to do certain things in a CDI education program. We want to follow certain, we want to track, would be the best word, our metrics and our statistics around our performance. So certain things that we can measure, or we should be being measured, or if we're in a system, which is very interesting because outpatient CDI is still evolving, do not be surprised if you are tracking your own work, if you're measuring your own performance, right? So with that being said, looking at things like query rates, you would also be looking at your query response rates. This is the provider responding to those queries. So when you're seeking that clarification about the documentation, are the providers actually responding? Is there a process in place if they're not responding? Can those queries be escalated? Should they be escalated? What is that process, right? So also the response rate, the claims denial. Okay, so these are for missing or inadequate documentation. So for the most part, the most simplest word I probably could use in this term here is medical necessity. So if in the documentation does not support the services or the condition that was documented, most likely it's going to result in a denial, because payers are not going to take on the financial burden of covering the cost for a condition if it is not clearly supported and documented in the record. CDI mismatch. This happens, of course, when you're doing queries. There's going to be sometimes you're going to query a provider about something. The provider is going to say, well, that's not the way I seen it. That's not, the condition I was thinking. I thought that I provided enough information for this diagnosis or that treatment. And so, again, our role is not to tell the providers what to do. Our role is really to ensure that the provider has the support, the integrity to stand for that condition or that record to be defensible, right? And so that validation is really coming from what's in their documentation. So we're not going to argue with them about their clinical decisions. We're really talking about the support in the documentation. Coder mismatch also can happen where a coder selection can be different than the providers. If there's disagreement, that can also be tracked. And all of these are opportunities for you to tighten up and be more specific in what you're tracking as far as your performance in your CDI program. And it's also an opportunity for you to look at your own approaches. So if as a CDI nurse, you are, you notice that you're having the same providers have the same mismatches, or if there are particular conditions that you see tend to be more difficult for the providers to capture with specificity and with support, that can help tailor your CDI program. So I'm actually going to stop sharing now. I'm going to pass it over to the coding nurse so we can learn about inpatient CDI. Mm-hmm.
So the purpose and function of CDI is, especially inpatient CDI, is to clarify ambiguous clinical documentation. That's the bulk of your job. Then also to establish a working DRG, which is the next biggest part of your job. You also function as a liaison between clinical and coding. And last but not least, your purpose and function is to maximize reimbursement. And you maximize the reimbursement by making sure that every diagnosis that is documented and coded to the highest level of specificity. Then the required skills for inpatient CDI. You have to have medical coding knowledge. I don't know how you can do any kind of CDI without having any kind of medical coding knowledge, because when you are working in inpatient CDI, the chart has not been coded by anybody, because you're seeing this patient 48 hours after admission and you follow them through all the way to discharge. So if you don't know how to code conditions and how those conditions relate to each other in terms of the inpatient prospective payment system, you will be lost. So you have to have medical coding knowledge. You have to have clinical knowledge, because that clinical knowledge is going to help strengthen your medical coding knowledge to make sure that all of the conditions that are documented are clearly documented and coded to the highest level of specificity. Then last but not least, you have to be able to do compliant querying, because that is very, very important. Because, querying is really important, and you do not want to lead the providers, because you cannot tell the providers what to do. You just have to ask them, can they clarify based off of the information that you present that you found in the medical record? So that leads us to, we're going to talk about the inpatient prospective payment system. The inpatient prospective payment system is made up of two types of DRGs. We have MS-DRGs, which are medical severity DRGs, and APR-DRGs, which are all patient refined DRGs. MS-DRGs are for people over 65 and the disabled, and the MS-DRGs are determined by CMS, the Centers for Medicare and Medicaid Services. And the MS-DRG is affected by CCs and MCCs. We're going to get into that a little later. The APR-DRGs are for commercial plans or everybody who's not on Medicare. And the APR-DRG system has two components. We have an SOI, which is the severity of illness, and then ROM, which is a risk of mortality. The APR-DRG is affected by the severity of illness, and I'm going to get into that a little later. So the medical severity or MS-DRG hierarchy is, at the base, you have no CC or MCC. Then at the next highest level, you have a complication or a comorbidity, which is a CC. Then at the top, you have major complication or comorbidity, which is an MCC. And for each stage you go up, you get a different DRG assigned, and it comes with a different weight. So the higher you go up, the higher the DRG weight, and the DRG weight is what ultimately determines the payment that the hospital will receive for that admission. And the MCCs and CCs are based off of secondary diagnoses, because whatever your primary diagnosis is, that's going to get you into a bucket. But your CC and MCC will determine how you move up in the bucket. And some DRGs don't have a CC or MCC. Some of them only have an MCC. So it depends on the principal diagnosis and or if the person had surgery. So, and you do all of this with the help of an encoder. But for MCCs and CCs in particular, if you have an inpatient ICD-10 CM coding book, the tabular index will let you know if a condition is a CC or an MCC. And it won't tell you the weight. You need an encoder for the weight, but it will let you know if a condition is a CC or an MCC. Then we have the SOI and the ROM hierarchy. Both of them have a scale of 1 to 4, but as I mentioned earlier, the SOI is the only thing that is going to affect the DRG weight for an APR DRG. And the hierarchy goes from 1 to 4, which is minor, moderate, major, and extreme. And each level will increase the DRG weight, because in MS DRGs, each level, whether it's a no MCC or CC or MCC, you have a different DRG assigned to that, which will have a different weight. In the APR DRG system, you will have the same DRG, but the SOI will change. So if it's a 1, it will have a weight to it. If it's a 2, it'll have a different weight to it. 3, 4, so on. And when you validate, you want to make sure that any level that you have is supported. And that's why you will want to make sure that you query if you have and if you have any kind of like unclear or ambiguous information. So now we're going to go into a case study. So we have a 67-year-old female presented to the ED with nausea and vomiting times 2 days and fever and cough times 1 day. Patient has a past medical history of dysphagia secondary to a CVA several years ago. The chest X-ray showed bilateral lower lobe infiltrates, admitted with diagnosis of pneumonia, treated with IV cefepime for several days, and was discharged on oral antibiotics. So this is where your coding knowledge is going to come in, because if you don't know how to code a dysphagia secondary to a CVA, you're going to really miss the meat and potatoes of this scenario. So that will be considered a sequela. And if you know coding, you know how to code a sequela secondary to a CVA. So what we are going to look into next is we're going to look into the validation criteria. So to validate pneumonia, you need a diagnosis, you need signs and symptoms, you need imaging, and you need treatment. So we're going to go back to the scenario. We're going to pick it out. So we have a diagnosis, is diagnosed with pneumonia. We have signs and symptoms because they had a fever and cough times 1 day, which that would indicate pneumonia. They also have imaging because the chest X-ray show bilateral lower lobe infiltrates, and they were treated with IV antibiotics and they were discharged on oral antibiotics. So the criteria for pneumonia is met. Now we're going to look at the criteria for aspiration pneumonia. So aspiration pneumonia has the same criteria, but one extra component. So we have to have a diagnosis, we have to have signs and symptoms, we have to have imaging and treatment, just like in regular pneumonia, but the extra caveat is we have to have a neurological or gastrointestinal deficit. So if we go back to the scenario, we know that we validated pneumonia, but we also have a neurological deficit because a person has dysphagia secondary to a stroke several years ago. And they also had nausea and vomiting. So that would be a G. So they cover all the bases. So because this person met the criteria for both aspiration pneumonia and pneumonia as a CDI, you will learn over time that aspiration pneumonia has a higher DRG weight than regular pneumonia. And since the provider just documented pneumonia, we cannot just say, oh, well, they met the criteria, so we can just code aspiration pneumonia because we're not clinicians. We're not able to do that. Well, we're not providers. Only providers can assign diagnoses. But we do have enough information to formulate a query. So if we look at the query opportunity is to specify the type of pneumonia. So we need the specificity of type of pneumonia. Then we have the clinical indicators: nausea and vomiting for 2 days, dysphagia secondary to CVA. We have bilateral lower lobe infiltrates, and they were treated with IV cefepime. Then for the specificity options, for the query options for the provider, we have aspiration pneumonia, we have pneumonia unspecified, and we have other. Whenever you send a query, you always want to give the provider the option of other, just in case they don't agree with any of the choices that you offered. And any choice you offer has to be sound, and it has to be based off of sound clinical information. You just can't make it up. So next we're going to look at the screenshots from the 3M encoder to show you the financial impact and the DRG impact for the two conditions. So if the provider just came back and said, well, this person does have pneumonia, or just say you didn't send a query and you just coded it as pneumonia. We see at the top, we have a DRG of 195, we have a weight of 0.6285, and we have a total of $3,273.64. And we see down here, the admit diagnosis was nausea and vomiting, but we see the principal is pneumonia, unspecified organism. And this is how you would code dysphagia secondary to a CDA. And it requires 2 codes. And it also mentioned, because we have to have the dysphagia because that's what is called dysphagia following cerebral infarction. But the coding guidelines specify that we also have to specify the type of dysphagia. And they didn't give us any more specificity, so you just code dysphagia unspecified. So this is for regular pneumonia. Now we're going to look at the 3M coding for aspiration pneumonia. So if we go to aspiration pneumonia, we see that our DRG changes to 179. We see our weight has increased to 0.755, and our total dollar amount has changed. It has increased to $3,872.78. And the only thing that has changed is the principal diagnosis, which we see down here is J69.0. So if we look at this, I put a little graphic so you can see it side by side to make it clearer. If you have regular pneumonia, in the middle column, we see the DRG, we see the weight, we see the reimbursement. If we go to the far right, we see the aspiration pneumonia, we see the DRG is different, we see the DRG weight is different, and we see the reimbursement is different. So the financial impact from sending that query is a positive financial impact of $599.14. That may not seem like a lot of money, but when you consider all of the millions of hospital encounters, if you can increase the financial impact on your cases, then you're increasing the financial solvency of your organization. And it's all based off of your knowledge of your clinical knowledge and your knowledge of medical coding and the inpatient reimbursement payment system. So that's all I have. And I also wanted to briefly mention that on January 12th, I have a new ICD-10 CM course that will be forming at 6 p.m. Eastern Time. It's going to be for 8 weeks, Mondays and Wednesdays from 6 p.m. to 8 p.m. Eastern Time. And if you would like more information, you can either contact me at the email address at the bottom of the screen or visit the website at the bottom of the screen.
Thank you. Now, stick around to learn about our upcoming events. Our monthly Saturday workshop. This isn't just another seminar, it's your launch pad. Each Saturday, we move beyond the theory and provide the direct, actionable blueprint to pivot from the bedside into a high-impact, sought-after clinical analyst role. Through our Clinical Analyst Skill Translator and Strategic Application Toolkit, you'll gain the precise framework to translate your nursing expertise into a value-based career. Stop wondering what's next. Start building it. For the special MLK Day event, on January 19th, we honor the legacy of Dr. Martin Luther King Jr. through a commitment to professional and financial empowerment. This special evening event, Legacy and Leverage, is dedicated to helping you chart your next chapter. It's a unique opportunity to reflect on your journey, leverage your invaluable nursing skills, and strategically position yourself for a high-value career that amplifies your impact and fulfills your vision for the future.
We want to hear from you. Schedule a free consultation or send us an email at advancednurses@acd4n.com or visit our websites www.advancednurses.info or www.acd4n.com.